Welcome back to NGN Deep Dive. Today, Neuro Emergencies. Stroke and the last known well clock, rising intracranial pressure, and its earliest sign. Autonomic Dysreflexia, and Myasthenic Crisis. Crisis. These are time critical, and each has a signature first move. Roadmap. Stroke and the last known well window. Rising ICP and its earliest sign. Autonomic Dysreflexia. Myasthenic Crisis. A head-to-head, and practice from days 5, 11, 23, and 22. Chapter 1, Stroke. Time is brain. The whole management hinges on two questions. Is it ischemic or hemorrhagic? And how long ago did symptoms start? Here's the fork. A sudden focal deficit appears. You get a non-contrast CT first to rule out a bleed. If it's ischemic, a clot-blocking perfusion, a clotbuster like TPA can help, but only within the time window. If it's hemorrhagic, a ruptured vessel, TPA would be catastrophic. That is why the CT always comes before any clotbuster. The numbers. Last known well is the critical time, not when symptoms were found, but when the person was last seen normal. IV TPA is generally given within 3 to 4.5 hours of that time, if there's no contraindication. Mechanical thrombectomy can extend to 24 hours in selected large vessel cases. Blood pressure must be under 185/110 before TPA. And always check the glucose, because hypoglycemia can mimic a stroke. If-then rules. For a sudden focal deficit, note the last known well, and get a stat non-contrast CT. If the CT shows no bleed and the patient's within the window, screen for TPA eligibility. If it's hemorrhagic, no TPA. You control the blood pressure, manage the ICP, and do frequent neuro checks. And after TPA, watch closely for bleeding. Chapter 2. Rising intracranial pressure. The skull is a rigid box holding brain, blood, and cerebrospinal fluid. When one grows, pressure climbs, and perfusion to the brain falls. The single most important teaching point. The earliest sign of rising ICP is a change in the level of consciousness. Restlessness, confusion, a subtle decline. Pupils become sluggish or unequal. Late signs are Cushing's triad, a rising blood pressure with a widening pulse pressure, a falling heart rate, and irregular breathing, plus projectile vomiting and posturing, which is very late and ominous. Cushing's triad is a late sign. Don't wait for it. Management protects cerebral perfusion. Elevate the head of the bed to 30 degrees. Keep the head midline and the neck untwisted to promote venous drainage out of the skull. Prevent pressure spikes. Minimize suctioning and cluster your care. Osmotic therapy like mannitol or hypertonic saline pulls fluid out. And control carbon dioxide with ventilation while avoiding hypotension, which would starve the brain. Chapter 3. Autonomic Dysreflexia. In a spinal cord injury at or above T6, a noxious stimulus below the injury triggers a massive, uncontrolled sympathetic surge. It's a hypertensive emergency. Recognize it fast. In a patient with a spinal cord injury at or above T6, a sudden, severe spike in blood pressure, a pounding headache, a slow heart rate and flushing and sweating above the level of injury, with pale, cool, goosebumped skin below it. That split, hot above, cold below, is the classic sign. Act now. First, sit the client bolt upright. That uses gravity to lower the pressure immediately. Loosen any tight clothing or devices. Then hunt the trigger, and the most common one is a distended bladder. Check for a kinked or blocked catheter. Next, check for bowel impaction. If the pressure stays dangerously high, give an antihypertensive. Sit them up, then find the trigger. Chapter 4. Myasthenic Crisis. In myasthenia gravis, an exacerbation can weaken the breathing muscles to the point of respiratory failure. The airway is the whole game. The priority is always the airway. Myasthenic crisis brings severe weakness of the breathing muscles, a falling vital capacity, and a weakening inspiratory force. Swallowing is impaired, so Aspiration is a real risk. Your priority is to monitor respiratory status closely and be ready to intubate. It's usually triggered by infection, stress, or a missed dose of medication. One classic comparison the exam loves: myasthenic versus cholinergic crisis. Myasthenic crisis is too little medication, undertreated disease triggered by infection or a missed dose. Cholinergic crisis is too much anticholinesterase medication, and it adds sludge symptoms: salivation, tearing, diarrhea. Historically, the hydrophonium test improved myasthenic weakness but worsened cholinergic. Either way, both threaten the airway, and that's your priority in both. Practice. From day 5. A client with left-sided weakness and slurred speech that started 90 minutes ago. What's the most important thing to establish immediately? Pause and choose. The answer is B. The exact time last known well. Eligibility for TPA and thrombectomy hinges entirely on that time. It decides whether the client is within the treatment window, which is the most time-critical piece of stroke data. The other options matter for later care, but none drives the emergency treatment path the way last known well does. Second question, from day 23. A client with a T4 spinal cord injury suddenly has a pounding headache, a blood pressure of 208/118, and facial flushing. What does the nurse do first? Pause and decide. The answer is B. Raise the head of the bed and sit them upright. This is autonomic dysreflexia, and sitting up uses gravity to drop the dangerously high pressure while you hunt for the trigger, usually a full bladder. The trap is D, lying flat, with legs up. That's the reflex for hypotension. But here it would raise an already dangerous pressure. Recognizing this is severe hypertension, not shock, flips the position entirely. Synthesize it. Center. Autonomic dysreflexia. Actions. Sit the client upright immediately. Assess for and relieve a distended bladder. And give an antihypertensive if the pressure stays critical. Monitor the blood pressure every few minutes, the headache resolving, and bladder and bowel output once the trigger is removed. That's the whole reflex managed in one bow tie. That's the Neuro Emergencies: stroke, rising ICP, autonomic dysreflexia, and myasthenic crisis. Daily NGN questions at 5. Every guide free at ClinicalJudge.com. Subscribe, comment your score, save the series. You learned it. Now go apply it.